Hello, everyone. Welcome to Thursday VMR. I was telling everybody behind the scenes that yesterday was one of those really fun days in the emergency room where you have to use all your energy. So I have very little left this morning, and I'm going to use it all in the intro, and then just sit here while our beloved Andrew dissects this case solo. Although I think that that's a lie because I love medicine, but also because Andrew might rejuvenate me in discussing this case. I do want to before introducing Andrew share that another reason why I'm feeling jittery is because we have a David case. And if you ever listened to David present a case before, you know you should be mightily prepared, especially since we know that he has an image for us to share, which makes me even more nervous. But I'm very, very excited to discuss his case. And I was thinking about what I would share about Andrew along the way here as I drove from home. I'm in my office now, for those of you wondering about the unusual scenery. And I think that there's nothing more telling than what would happen if you were to open up the origins of VMR a long, long time ago about 4 years ago. You would see Andrew in his medical student years prominently sharing his thoughts. And slowly but surely, you would realize, oh, wow, like this is a very, very talented medical student. And then you would probably get very, very sad because you wouldn't see Andrew for quite some time as he jumped into his intern year and was surviving residency. And then all of a sudden, the lights would go on again and you would see the reemergence of Andrew Sanchez, and yet you would realize, oh my God, I'm literally seeing that potential bear fruit. And now Andrew has joined the CP Solvers Academy a few months ago. Uh, he was a prominent part of other aspects of CP Solvers, but finally had the bandwidth and the time to make it into this space. And he's been very, very active since his very involvement and has already actually begun to facilitate cases. So if you haven't seen Andrew facilitate, I'm thrilled to be able to do that with him today. This is the first time that we get to do it with Andrew as an Academy member, though I had the chance to kind of sneak co-facilitate with Andrew. But it's really, really cool to see your journey symbolize what VMR is about. And I think there's nothing more aligned than what you love to do and what VMR does. And we're really, really excited to celebrate that today. And it's cool that it's caught on tape, honestly. And my hope is that we can have a similar conversation about your attending hood and when you're a full professor, you're like, oh, I remember when Andrew was just beginning attending and we discussed on VMR. So here's to the beginning of a new chapter, but hopefully the beginning of a very, very long book for you. And we're very, very excited to welcome you here to this space. And I'll pass the mic to you to say hello. And then
Jeez,
about it.
Rabih, you weren't kidding. No, it's been a joy to be part of the space for so long. CP Solvers has been a part of my life since my M4 year, and really learned like at least 90% of medicine in this space, and really how to approach medicine and how to learn here. And it's always a blast to be around. So, thanks for having me. And I'll try and pull my weight today since it's a David case, as you said. So, looking forward to this case, David.
Okay, so when you want, I'll start. Okay, so this is a 64-year-old female who's brought to the ER with 1 day of disorientation, incoherent speech, and abnormal behavior. She was found hitting her home's door and asking for help, and this didn't make sense to the family. Um, the family told us that she had also fall in the shower, but they didn't thought that she got any trauma. And in the past day, she was okay. She didn't have fever, no vomiting, no diarrhea, no abdominal pain, no chest pain, or no dyspnea. And this is the first article.
Wow. Okay, Robbie, this is going to be an interesting case. Why is that? I'm going to frame this as altered mental status. I think we were given two problems in this first aliquot. One is this kind of conglomeration of neurologic symptoms, which for now I'm just going to make super broad and call it altered mental status, with the understanding that that's not a very specific term, and neurologists often try and categorize what type of altered mental status it is. But we're in aliquot number 1, so I'll keep that altered mental status. And then the second thing we're given is a fall, which of course could be tied neurologically speaking to altered mental status. But I think we're going to need an exam and more information about that fall event really to consider that significant and make progress. So how do you approach altered mental status? I think the very classic mnemonic is very, very helpful. Really quickly, before I go into a very broad differential though, using that mnemonic, which I'm going to alter a slight bit, you want to consider really like emergent causes of altered mental status. There's a separate mnemonic for that I use in the hospital. That is SCAN, SCAN. So first I want to know a patient's sugar. So get a quick finger stick to make sure that they're not hypoglycemic. Number 2 is C for CT head. That's for a quick rule outs of very large intracranial pathology, like large bleeds, large strokes, but being insensitive for small strokes. A is for ABG/VBG, because you don't need an ABG to tell if someone's hypercapnic or not. You can just get a VBG. Make sure someone's not retaining CO2 with that gas. And then and then N is for narcotics, and that's particularly important in hospitalized patients because patients are getting a lot of opioids. So you can consider Narcan in patients. So hopefully we get some quick information like en route, obviously had a CT scan on the way en route, but that's kind of how I approach acute altered mental status. But for broad altered mental status, I modify the MIST mnemonic to MINT, and I'm going to go through that. So M is for metabolic causes, and in your head, I just basically fill in the fishbone diagrams with all of the electrolyte abnormalities and metabolic abnormalities that can cause altered mentation, including sodium derangements in both directions, very, very high BUN causing uremia, hypercalcemia. And then there's some other ones like off the fishbone diagram that you can consider, like hyperammonemia, so sending an ammonia, thyroid derangements, sending a TSH. And then in older folks, I just put in here like urinary retention just as another, I know it's not metabolic, but in my head is kind of like where I put it. I have to put it somewhere. So, okay, that's metabolic. And there are a couple other ones I didn't mention. I is for infection, and you split that into intra-CNS versus extra-CNS. Since this is an older patient, we always say in this space that they're more prone to extra CNS issues causing altered mentation. So older people being more predisposed to UTI causing altered mentation. But if it's a younger patient, you're really focused on what could be going on in the brain, like meningitis, encephalitis, brain abscess. Okay, N is where I deviate from the MIST mnemonic. And I could split up, and I got this from Rabih actually. It's not around Twitter much anymore, but he tweeted this forever ago. I split N into neurologic causes instead of just plain old structural. And I think about that in pre, intra, and post brain issues, just like as if you were approaching like an AKI. So for pre-brain issues, basically think of decreased inflow issue versus increased blood inflow issue to the brain. So anything that makes someone hemodynamically unstable or with poor oxygen delivery will cause altered mentation, from like shock. Hypoxemia can do this in the form of hypoxia. And then for the increased issue, I believe it's PRES is technically increased blood flow into the brain can cause this. It's like technically the pathophys. And then severe hypertension, like in a hypertensive emergency, can do this. So those are pre-brain issues. Intra-brain issues, you can think of what can fill a space. So does this patient have a lot of extra fluid around in the form of an abscess, a hemorrhage, or hydrocephalus? You can split it up into increased neuronal activity. Is the patient having a seizure, or you can also think of increased cellular activity in the form of like inflammation, like is this patient having vasculitis? And then I also think of like decreased neuronal activity, and these are like kind of diagnoses of exclusion, like catatonia being something that could be kind of like a mimicker. And then finally, T is the last one. These are your classic toxic causes of altered mental status. So we really need to talk about potential medication changes, withdrawals, and substance use history. etc. And sorry, going back, I got excited. We didn't talk about post-brain. The one big post-brain issue that I consider is cerebral venous sinus thrombosis causing a poor outflow of the brain. So I'll stop there. I warned you that it was going to be very, very broad, but getting more information is going to help us kind of, tailor that differential diagnosis.
Andrew, I think that what you're doing is illustrating a very key principle, which is that whenever you hear little data, you want to actually put out the entire roadmap that's possible. And I think that you cannot diagnose the condition before you in the patient if you don't have a consideration for all the range of possibilities, right? Like you'll never find the right answer if your comprehensive list of differential diagnosis does not include the answer. So what happens in medical school and in training is you are taught all these conditions. And it's a little bit overwhelming when you start to see patients because you're like, well, I know these conditions, but I have no idea how to figure out if this patient has this condition. And part of that is learning to identify how to navigate a pathway to the answer. And the biggest and most important thing is to try to understand the nature of the problem. And here you framed it very well. You're like altered mental status, and you have an approach for that. And then as you start to look at that list and be like, okay, it's very exhaustive and comprehensive. And is there a theme that helps me subdivide it and make it more actionable and digestible in the moment? And you taught us, well, yeah, there is. There's things I never want to miss. And those I'm going to subdivide into a scan mnemonic and think about those things right away. And that's one very, very helpful way to think about it. In terms of altered mental status, I think one very practical consideration is it an internal medicine problem manifesting in the brain, or is it an inherent neurological condition? In other words, is this issue residing in the brain alone, or is this a systemic disease that is either macroscopically or microscopically affecting the brain? So, does this person have a glioblastoma? Or does this person have a metastatic tumor to her brain or a effects of an ingested toxin? And that's what you're fundamentally trying to do, is to be like, is the problem restricted to the brain alone, or is something pouring in from the outside? And that's part of the reason neurologists are very particular about the term altered mental status. To a neurologist, altered mental status really means a reduction or alteration in the level of arousal. How awake or sleepy are you? The reason that that term is non-specific is because diffuse cortical dysfunction, diffuse, often from a systemic problem, is at play. If you have findings suggestive of a focal cortical problem, then your problem isn't altered mental status. It's whatever word you want to use to represent a focal neurological lesion. This gets complicated because when patients have focal temporal lobe or frontal lobe or even parietal lobe lesions, their engagement with the world can change such that they are either have personality changes or they have abnormal behaviors or they don't talk right. So an example would be you have a frontal lobe meningioma and your personality changes, or you have a temporal lobe problem and your speech is changed. So I think you have to be very, very careful to be like, well, what's the problem here? And I think I'm really interested in understanding this person's level of arousal. Because if we are assuming that her level of arousal is intact enough that she can knock on the door, and yet she is having disorientation, incoherent speech, abnormal behavior, I'm struggling to figure out, does she have altered mental status? Or does she have focal, cortical, or basal ganglia dysfunction? It's hard to know from the get-go without examining the patient what the accurate problem representation going to be. Is it going to be diffuse cortical dysfunction or is it going to be focal disease? But anytime you have changes in brain function that do not involve level of arousal, your antennae should be up for an intrinsic neurological issue with focality. And that's what I'm really, really suspicious about here. And the reason it changes your management is it reduces the distance between the initial workup and more advanced neurological diagnostics. In a patient like this patient, this time between arrival and lumbar puncture, and the time between arrival and MRI, and the time between arrival and neurological consultation is much shorter if no alternative cause is quickly found. So I really like that you brought attention to that. Hopefully, in this conversation, I've articulated why neurologists pin on that, but we'll have to start systematically. First scan, then the regular old missed workup. But what's really going to happen is attention to detail on exam for other evidence of focality, and to not dwindle in the internal medicine category too long before moving to neuro. All right, David, please tell us more.
Oh, so very good discussion. Love how you said that not always other mental status is so directly diagnosed. The past medical history, she had mild COPD, hypothyroidism on levothyroxine, and she had an extrahepatic cholangiocarcinoma, stage 4, on chemotherapy. I'll tell you a bit of the history of this cholangiocarcinoma. It was diagnosed in 2020. It was resected by a cephalic duodenopancreatectomy, and she received adjuvant chemotherapy with capecitabine. In May of 2022, she developed a recurrence that was advised in a CT with a liver mass on the hilia. In that moment, she started cisplatin and gemcitabine, and she later received radiotherapy, local radiotherapy. And in December of 22, there was tumoral progression despite the chemotherapy. The hepatic ileal mass increased and appeared pulmonary nodules and ascites. And in that moment, she started FOLFOX. The treatment is what I said: levothyroxine, lorazepam, and FOLFOX, fluorouracil oxaliplatin. That the last cycle was 3 days before the presentation. Family history is none. Social history: she lives with his son. She's independent. She's a past smoker since 3 years, 40 packs a year, and she doesn't drink alcohol or use any other drug, and no allergies. And I can stop there if you want.
Yeah, that's perfect, David. There's a lot of fun information we can play around with here to kind of layer on to that broad DDX that we talked about earlier. And I'll try and stick to this approach of like time to like next test to like try and get an answer quick for this patient and kind of think of like the most morbid things that could be going on first. Since she's recently getting FOLFOX, like cytotoxic chemotherapy, that makes me think of, could this patient have very, very low cell counts, including like a deep thrombocytopenia that could be leading to like a brain hemorrhage. So, we're definitely getting a CBC here to see how low her cell counts may be. And then, of course, we're going to get that head scan right away with the head CT to make sure there's no large bleed. We talked about things spreading to the brain already. So, with the stage 4 cancer, tumor to the brain is on the table. I don't know if I've ever seen cholangiocarcinoma go to the brain. I'm sure it can do it, but I don't know if I've personally seen that before. And infections, this patient, is going to be at risk of infection since they're receiving chemotherapy. They have a background of COPD for bacterial seeding in the lungs that could go to the brain. And then finally, I'll just comment if this patient's been overdosing on lorazepam, that could be contributing to hypercapnia, given the COPD history. So definitely getting the blood gas will be important. But yeah, this definitely adds a nice layer for us to think about the problem a little bit more.
You know, I love that your master approach, Andrew, is to say cancer related to altered mental status, and your instinct was actually first to think about interventions from cancer. And I couldn't agree more with you. I think most of the time, while we worry about cancer going to the brain as the connection between cancer and altered mental status, I think the more apt considerations are to think about the interventions for the cancer. And I would bet that they're more common. Drugs we give patients, radiation, nutritional deficiencies, and even honestly just a reduction in the reserve of a patient with a systemic cancer can sometimes result in depression and basically mediation of neuropsychiatric changes without structural changes in the brain. I completely agree with you. I'm really curious. We're definitely going to get an exam. I'm really curious what your first pass thinking about those tests, right? You're going to get the scan. You articulated that very well. I couldn't agree more with you. Um, what would you be ordering, assuming the exam doesn't radically change the problem? What do you think you'd be getting right now?
Yeah, I think there's a lot of stuff we can grab, and it'll be pretty broad. We said the cell count already. I think a full metabolic panel, including LFTs, will be really important. We can compare any background of, mild elevation in transaminases, mild elevation in bilirubin. If we were to see like large spikes in that, that may make us worry that perhaps there's cholangitis and a systemic infection causing this syndrome is really like an extra brain issue. And there are paraneoplastic things, hypercalcemia. I don't think you see that with cholangiocarcinoma, but add a calcium on. We said blood gas already to make sure they're not hypercapnic. And then, the ammonia would probably be controversial because having an elevated ammonia doesn't necessarily mean you have hepatic encephalopathy, but we can check for asterixis on the exam and see if that would be supportive of having it. It's not specific for hepatic encephalopathy, but that would point us in a direction of at least looking for what could be causing asterixis. And I've definitely seen patients with hepatic encephalopathy from like profound tumor burden, portal vein thrombus, like kind of on top of that, et cetera. So yeah, probably CMP, CBC, calcium, nutritional stuff too, like FOS, VBG, cell count, if I didn't say it already.
Yeah, no, I think that's absolutely superb. I think the first pass workup for most people, altered mental status, is a CBC, a comprehensive metabolic panel, and to consideration of a blood gas. And what that does is really you're looking for infections with the CBC, and then the metabolic panel is looking at metabolic diseases, the kidney, with the creatinine and the BUN, and the liver enzymes to implicate hepatic diseases. And then the VBG is helping you figure out if you have a respiratory acidosis as a contributor. Now, this is a key point. How good is the BUN and creatinine at assessing uremic encephalopathy? And the answer is not perfectly. You could have a uremic encephalopathy with a very underwhelming BUN, and you could not have any encephalopathy with a super high BUN. And that's because we now recognize that there are many other nephrotoxins that accumulate in the body that are not captured by the BUN and creatinine. So, is the BUN and creatinine a perfect measure of uremic encephalopathy? The answer is no. Is ammonia a perfect measure of hepatic encephalopathy? The answer is also no. But there's some nuance with hepatic encephalopathy. It comes in 3 different flavors, and it has to do with how the liver is dysfunctional. The first label is the liver overtly dysfunctional, either in the form of acute liver failure or in the form of chronic liver disease. Those are 2 out of the 3 ways that you can get hepatic encephalopathy, and they're very well named. Type A hepatic encephalopathy is acute liver injury, and type C hepatic encephalopathy is from cirrhosis. The mysterious category between A and C is type B hepatic encephalopathy, and that's That is a very interesting space where you have accumulation of hepatotoxins without overt hepatic dysfunction. How does that happen? That happens because of a strategic lesion that impairs ammonia clearance, either as a result of portosystemic shunts that bypass the liver, or as a result of urea cycle issues that can be genetic or acquired. So if you're understanding metabolic encephalopathy, you'll divorce BUN and creatinine from uremia, and you will add nuance into the type of hepatic encephalopathy you're considering. Does this patient have type C hepatic encephalopathy? No, she has no evidence of cirrhosis so far. Does this person have type A hepatic encephalopathy? Possibly. We don't know her liver enzymes yet. She could have drug-induced liver injury. Does this person have type B hepatic encephalopathy? And the answer is she could because of the 5-FU. But we're going to leave that to a separate conversation. The conversation that you were having, Andrew, is what is the role of ammonia testing in patients with suspected hepatic encephalopathy? Ammonia is a phenomenal test for acute liver injury, and the degree of ammonia elevation correlates with the degree of hepatic encephalopathy in type A hepatic encephalopathy. In type C hepatic encephalopathy or cirrhosis, it is abysmal. Why? Because so many other non-measured hepatotoxins correlate with altered mental status. How does it perform in type B hepatic encephalopathy? Phenomenally well. There is no other way to diagnose type B hepatic encephalopathy than to demonstrate a high ammonia with normal liver enzymes. So when you're trying to think about ammonia testing, you really have to ask yourself, well, what kind of hepatic encephalopathy am I worried about? And if you're worried about cirrhotic hepatic encephalopathy, it's not worth it. If you're worried about type A, acute liver injury, which we have no reason to worry about yet, or if you're worried about type B, where a patient either has a portosystemic shunt, which could happen because of a cholangiocarcinoma, or the patient has drug-induced urea cycle dysfunction, the 5-FU, an ammonia test is an excellent test. You just have to be careful how you obtain it, and it has to be collected without a tourniquet and set on ice and immediately analyzed. Otherwise, it's a very noisy test. So in this patient, I think it would be very common for the value of ammonia to be overlooked, but I think it is a potentially very powerful test in this patient, either in the first pass workup or in the second pass workup should nothing be revealing. Any thoughts or questions on that distinction of the types of HE and where ammonia may or may not be helpful, Andrew? How does that sound to you?
I'm always learning something from you, Rabih. That's new to me. I really like how you broke that down in terms of the utility of the hyperammonemia. My one question is how the 5-FU plays into the hyperammonemia.
Yeah, so the type B hepatic encephalopathy refers to either bypassing the urea cycle or inherent dysfunction. Inherent dysfunction comes in the form of genetic diseases, but also drug-induced inhibition of the urea cycle. And if you're going to remember two drugs that inhibit the urea cycle, valproic acid is the leading one, and 5-FU is on the list. There are many other medications with weaker associations. The third category is nutritional deficiencies, with zinc deficiency being another manifestation. So acquired urea cycle issues, think medications and nutritional deficiencies, and the meds are valproate, 5-FU.
Perfect. I
All
feel like
right.
David's got some exciting information for us, Zach. This is already so rich.
Oh my gosh, we babble. I told you I would be quiet. Here I am. You've rejuvenated me, my friend. All right, David, tell us more, please.
Okay, amazing discussion so far. So I'll give you the exam and the first labs. The temperature was 37 degrees Celsius. Blood pressure 135/63. Heart rate 84. Respiratory rate 16. The SpO2 was 95 on room air. She was not in acute distress. Cardiovascular and pulmonary exam was normal. Abdomen was soft, non-tender, non-distended. Extremities and skin, she didn't have any rash, no leg swelling, no signs of DVT. Neuro, she was sleepy, confused, and disoriented in time and space. The language was coherent in that moment. She understood simple orders, but not complex ones. She had isochoria. The cranial nerves were normal. The strength in the four limbs were normal. The WBC was 9.66 with 85% neutrophils. Hemoglobin was 11, that was her baseline. MCV 96, platelets was 120. The INR was 1.1. INR 1.1. APTT 28 seconds. The sodium was 140. Potassium 4. Sodium 140, potassium 4, chloride 105, BUN 44, creatinine 1.35, calcium 9.4, ALT 35, AST 38, alphos was 200, and his baseline was similar. GGT was 160. That was similar to her baseline. Bilirubin was 1 and 1.4. Albumin 3.2. The CRP was 1 milligrams per deciliter. The BVG was pH 7.4, PCO2 34, lactate 2.3. Urinalysis was normal, no pyuria, no proteinuria, no hematuria. Chest X-ray was normal, no pulmonary obesities. ECG was also normal. And the head CT with and without contrast was normal. And I'll leave you with that.
Ooh, this is a spicy one. Rabih, I think our hyperammonemia discussion may bear fruit. I have a feeling because we got a lot of pertinent negatives here. I'm kind of thinking about that because David tells us the patient's sleepy. That's kind of what I think about with in terms of altered mental status. We talked about, describing a little bit more, sleepiness does make me concerned about hepatic encephalopathy. Um, we have a pretty strong metabolic panel not really pointing toward anything otherwise metabolic, like sodium's normal, creatinine, BUN are not impressive, the LFTs are at baseline. And finally, we ruled out the retention with the VPG. So I think we're going to need that ammonia at this point, Rabih. And the other thing we should talk about is the anisocoria, which I'll pass off to you since you're the ET
Oh,
physician. But my oh yeah, tell me, David.
sorry, the worst, both pupils were equal. There is
Okay.
isocoria, not an isocoria. So that's
Oh, okay. Okay. Yeah, we were gonna have to go down the road of like, are there other like focal deficits along with that? And like, we did get the head CT, so he's not herniating. Okay, so if it was there, it was just benign and it's chorea too. But yeah, I think I mean we had this rich discussion already on the hyperammonemia. I'm just trying to think of other things that we haven't talked about yet. I mean, she does take the lorazepam, so that wouldn't have caused CO2 retention here. But in terms of just kind of being on a background of like a weak patients and taking too much of it, I mean, I've definitely seen that before where someone's not like frankly retaining, but they like get fluids, they weren't eating much, you hold like a benzo and they just kind of get better. So I think that's still on the table too, but we should send that ammonia level. And the second question is, do we need to pursue like a brain MRI? And it seems like David got a pretty good exam here, despite the patient being sleepy. So it doesn't seem we have Frank's suggestion of another focal deficit that would make us concerned that we would need to get a brain MRI, but we should definitely talk about it a little bit more.
Really become very, very seasoned at this, Andrew. I think that what your ability to comprehensively analyze these labs and just ultimately say I'm underwhelmed is actually represents a lot of work that you've had to do, because I think it's very easy to be like, wait, the platelets are 120, that's not normal. The hemoglobin is low, that's not normal. The liver is dysfunctional in some extent, that's normal. But I think what your mind has now been very well trained at is to be able to see how confused she is versus how abnormal are her labs. And you're right, there's a disconnect there. Um, and I think not many people would have thought about sending an ammonia. We had a detailed discussion about it, not because I think I was preparing to, but because it was really cool that you thought of it and brought it up and opened the door to have that reflection. And who knows if the ammonia testing will bear fruit or not? It doesn't matter. I think the point that you have articulated is it is actually a fundamentally important test to get in this patient. And if we go back to the original conversation of like altered mental status is first scan, then the regular mist, and then crazy investigations focusing on the brain, MRI, LP, so on and so forth. Because we are having a fairly sort of nuanced and advanced conversation that I think the VMR crowd is certainly ready for, there's a little bit of a gap between the regular old missed workup and then the crazy brain stuff. And I've come to represent that gap as really the term subtle extrinsic altered mental status, meaning that the altered mental status is from an extrinsic source, but it's often hard to appreciate on the regular initial evaluation. And you keep bringing up one thing that happens to me all the time: urinary retention, urinary retention, urinary retention. What else? And this schema is from RLRCP solvers. I will tell you again, if you're not subscribed, I promise you you're really missing out, but that's okay. We can miss out on things sometimes. Um, the first pass workup is what you said. The second pass workup was completely life-changing when Mark presented a case of a patient who was altered, who ultimately had microangiopathic hemolytic anemia, but first actually presented with altered mental status before the MAHA labs bore fruit. That prompted a lot of reading and reflection on this possibility. And it's in the first pass, not because it's common. It's in the first pass because it's deadly. And I'll let you look at the second pass step just so you get a little flavor of what kinds of things are. I just saw Mark's comment in the chat. I can't sleep because of that case. Me neither, man. But this is the kind of stuff that I think you're alluding to, Andrew. You already mentioned toxins and how they can sneak by on you, and there's some very specific ones that can do. What's the flavor here? There's a lot on this slide, including ammonia, including some other fancy things. But what's the flavor here? It's diseases centered around the gastrointestinal tract, either nutritional deficiencies or toxic metabolic things. And there's a video on the RLR website that kind of explains this in more detail. So I think we're there. Right now, what phase of the workup are we in? We're in the subtle extrinsic phase. Before we are like, okay, I've thought of extrinsic, I've thought of subtle extrinsic, now I got to go intrinsic. And I think that's the big picture phase we're in. I want to put a pin in the VBG because I think it's a little bit interesting, but only probably couldn't get much juice out of it in real life. But based on the fact that this is a venous pH of 7.4 and the PCO2 is low on a venous, I suspect that this person has mild respiratory alkalosis. That's not normal. And it may be noise, but if it turns out, if the case goes in an interesting direction, then we can come back and reflect on how this data might be helpful, but it's not worth it now. But let's put a pin in that and come back to it. So I agree with you. The labs are underwhelming, and I would practice the space of subtle extrinsic AMS. Thoughts, questions before we move on?
No, love that schema. Thanks for sharing it, Robbie. I think we can ground ourselves. I made this cognitive step, but didn't say it out loud.
Yeah.
In the CRP, that CRP is not very impressive at all.
Mhm.
So I think it's a nice, helpful screen that we're kind of dealing with something non-inflammatory. So the jump I kind of made was low CRP and non-inflammatory, puts you more in like the metabolic realm of things.
Yeah, love it. It's such a great test when it's negative. It really alters the differential diagnosis profoundly. All righty, David, we're ready for more.
Okay, so in the ER, they reviewed the labs from 2 days prior that the patient had an appointment with the oncologist. And in that day, the labs showed this. The TSH was 169. The free T4 was 0.36. The CA 19.9 was 300, was increasing this tumor marker. And given these labs from 2 days prior, in the ER, they were concerned about mixed edema coma, and they started hydrocortisone and levothyroxine, and the patient improved in less than 24 hours. She improved quite frankly, and she started getting alert, oriented, and all of that. She was hospitalized, and in the next labs that were taken, the TSH was 6.5 and the free T4 was 1, but this was like 1 day and a half after starting the hydrocortisone and levothyroxine, because we can send it in the ER. And in that hospitalization, there was also done a CT, chest, abdomen, pelvis, because their oncologist thought that the tumor was progressing despite the FOLFOX. And the CT revealed that the pulmonary nodules had disappeared. So she responded in that way, but there were marked morphologic changes in the liver with the appearance that I'll share in the image. If Reyes can pass to yeah, that is. So the first two images in the outside, this was her CT from December 22, and the second two images were from the 3 months later, when she arrived to the ER with disorientation. The radiologist said that the liver had a pseudocirrhotic aspect and marked hilea retraction, and that was impossible to say if this was due to residual tumor or to changes post radiotherapy. They also described mild ascites and signs of peritoneal carcinomatosis. That is this article.
A marked change in the liver appearance. Ravi, what are we getting ourselves into here? Yeah, I mean, my initial thought with that is the tumor is progressing and perhaps causing more portal hypertension. Yeah, I will say I thought maybe we got like, it sounds like we're not done. I thought we got bamboozled and forgot to talk about the patient's hypothyroidism earlier, but it sounds like we're not quite done yet. So yeah, good catch on the low thyroid. It's funny, in most hospitalized patients, I really like disregard the TSH due to like the sick thyroid syndrome that kind of messes up all of the labs. But I think if you have a very, very high TSH and a confirmed low free T4, and someone who's a little sleepy, I think we can say that perhaps that was a contribution. But since you're giving us the imaging, I'm wondering if that new portal hypertension is causing more portosystemic shunting and hyperammonemia, and that perhaps this patient is going to kind of have like a recurrent encephalopathy, and maybe that's what comes next. And things that can trigger that. If it's a very, very large portosystemic shunt, I believe that's meat intake can still do this. One of my co-residents actually presented that in a patient with portosystemic shunt to one of our attendings, Dr. Chang. So you just have to be on the lookout for that. But yeah, Robbie, what do you think?
I agree with your thoughts to 100%. I think that now you have macroscopic evidence of, you have radiographic evidence of liver dysfunction without evidence of acute liver injury or cirrhosis in the labs. And so the idea of portosystemic shunts is very, very powerful. I think I was just trying to understand this really cool story. So David, when she got her TSH labs, she was not confused. Is that right? Or I just was trying to understand the sequence of events. Really interesting.
Yeah, that's right. Yeah. When she got these labs 2 days ago, she was all right.
Amazing. So, and then when she got the treatment for myxedema with Synthroid and hydrocortisone, when we say she improved, her labs improved, or what improved when she got that treatment?
She received that treatment and she was hospitalized, and yeah, in like 12 between 12 and 24 hours, her level of consciousness improved completely. And well, they thought it was maybe due to the hydrocortisone and levothyroxine, but we don't know really. We just know that she improved in very rapidly.
Um,
And
gotcha. So she came to the hospital. She was confused. People looked back and saw her previous labs at a time where she was completely asymptomatic, and they treated those labs, and she gets better. And I think that's the interesting disconnect is, did you say, did she get better because of those labs, or did she get better because of something else? And I don't know. I think a TSH, it's hard to imagine that the story of hypothyroidism is as abrupt in onset and resolution as it was in this instance. And so I think that, it's hard, you have two leads now. You have to have the liver lead and follow that up with an ammonia, and you have the thyroid lead. And I think the thyroid lead is one that's non-specific, biochemically based on endocrinological abnormalities, but it may push you to start to think, are there any other disturbances across the thyroid and brain axis that are mediated independent of the hormone level? And that is so rare and esoteric that it's probably not an actionable thought right now. I think there is some juice in the thyroid thread, and the learning there is there are connections between the thyroid and the brain that are independent of the hormone level. Here, the hormone level changes are too abrupt to be a perfect match for the syndrome before us. So I think, like you, Andrew, my focus would be on the liver, and to really make sure that we're not sitting on hyperammonemic encephalopathy, which can have a periodic waxing and waning phenotype to it. Yeah, I'm right there with you. All right, David, tell us more.
okay, so in that moment, that episode resolved and the patient restarted Folfox, and she didn't have any symptom till 3 months later. 3 months later, she came back to the ER with less than 1 day of disorientation, incoherent speech, and obnubilation. Pretty similar presentation as the previous one. In that moment, labs were normal, as similar as the previous ones. The CT head with and without contrast was also normal. She received flumazenil due to the concern of possibility of lorazepam overdose, and she didn't improve. She started deteriorating her mental status, and she went to the ICU. In the ICU, there was done an EEG for concern of non-convulsive status epilepticus that was normal. Well, no signs of epileptic activity, but just diffuse slowness. And it was also sent an ammonium, which showed 196 being the normal, like less than 50.
Wow, well, that's that escalated quickly. I'm glad that we have that to go off of, because then I think the next step is try and figure out if we can correct this. I don't know. The next step would be getting like an IV contrast study looking for said shunt and seeing if we could close it. And if that's negative, this would just be kind of just severe portal hypertension that we couldn't do much about because of like a large metastatic burden to the liver. I'm thinking it's going to be something along those lines, but I'm not exactly sure. I think I'd be consulting gastroenterology at this point to kind of help figure out where this ammonia is coming from, because it's going to be something, liver related, portosystemic shunt related. And then the treatment, I actually just saw Hans in the chat. Yeah, related to FOLFOX. I'm assuming that that's going to have to be taken out of the picture as well. Shoot, what do you think, Robbie?
I'm just really, I'm a little sad, honestly, because I can't tell you the number of times I've heard stories like this where just somebody suffers so long. And it's you just go show you have to be very careful when you're a teacher, and we're all studying to be that. People have been bashing ammonia for for hepatic encephalopathy so much, and honestly, with like a little bit of vitriol and anger, that it's caused this like really phenomenal test in two other circumstances to be completely like people are scared of getting an ammonia now. Yeah, you should be scared of getting it in cirrhosis, but like a simple test could have changed this person's life and mitigated her suffering for so long, especially when she's already like, 64 with metastatic cholangiocarcinoma. So I'm really grateful to David for showing us this powerful teaching point in a real life case. There are too many of these cases that we hear about, and I'm really grateful for everybody here who's making the time to learn this. And yeah, I think that the search should be next for a portosystemic shunt that can be embolized. In the meantime, you might think about addressing nutritional deficiency with zinc as a potential treatment. You might address the 5-FU and find another medication. You can also have ammonia scavenging medications, and actually in a patient who's this sick, you might even consider dialysis for the toxin removal aspect of it. Diagnostically, I think you're spot on. You got to see where this ammonia is being bypassed and what kind of portosystemic shunt might be at play here.
And
Yeah.
Robbie, I'll just add on, we mentioned the CT contrast study. I think that would catch a portal vein thrombus, but I just want to say it out loud for everybody. I do want to look for a portal vein thrombus as well. I've actually seen that before. Like a patient, this patient had cirrhosis that was in remission for 10 years, but then they developed a cancer, developed a portal vein thrombus. And this was all really being driven by a new CLL as a ammonia source, and kind of the combination of CLL cell turnover plus portal vein thrombus kind of led to a vicious cycle where we couldn't get this human's ammonia under control. So I think looking for a portal vein thrombus and a shunt would be helpful. But yeah, this is a really sad case.
So I'll tell you the rest of the course and the final DX, but just one question for you. What do you make of the CT abdomen and pelvis that was done in the previous hospitalization that relieved that the radiologist described that changes as pseudo-theoretic changes? Have you?
Yeah, I I've seen that in a Yale morning report. I don't know if it was a radiographic description, but really a syndrome of pseudocirrhosis where there's such a profound burden of metastatic disease to the liver that you kind of get this physiology. And I want to say the synthetic dysfunction remains viable. Don't quote me on that. But I think it's pseudocirrhosis is a condition of profound metastatic burden to the liver, and it has a particular like illness script that I'm not super strong on.
Yeah, me too. I've heard the term before, but it's not something that I can say with much confidence. It's like a little bit of an association that I have, but I don't know much about it. I'm excited to see what you've uncovered, David.
Okay, so I'll tell you. I'll well, I'll uh, dis- I'll tell you the rest of the course. In the ICU, um, can you hear me? Yeah, because I okay. In the ICU, the patient recovered like very rapidly in less than 48 hours. She was also alert and oriented and such as if anything has passed. Um, so this was thought to be an hepatic encephalopathy. The she in that time they the oncologist decided to stop the Folfox. um, it's true that the what Ravi told us that the fluorouracil could induce a hyperammonemic encephalopathy in this patient. So this was a bit of a concern. But this patient, 6 months 6 months after this episode, developed another episode of hepatic encephalopathy that resolved completely only with laxants, with lactulose. So this was thought to be an hepatic encephalopathy. And the question I was wondering when I reviewed this case is, why did this patient had an hepatic encephalopathy? In the second episode, they did an also other CT test, abdomen pelvis with contrast, and they didn't describe any changes. Um, it's true that they they didn't, and the oncologists that were in that moment, they didn't ask for looking specifically for a shunt that many times is missed if you don't ask the radiologist for this, and maybe they also need a arteriography to diagnose these shunts, because they are easily missed in common CTs. So the 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 question of why the hepatic encephalopathy is not solved in this patient, but reviewing the case, I think the most probable cause is a shunt. She had she didn't have cirrhosis because the hepatic function was normal. She had some changes of portal hypertension. She had mild thrombopenia and yeah, but no other signs of non-cirrhotic portal hypertension, and she didn't develop any esophageal or gastric varices that are more common than hepatic cephalopathy in those cases. And the pseudo cirrhosis is I thought, could this like behave like a cirrhosis cirrhotic patient with developing hepatic encephalopathy? But pseudothrombosis is a clinical radiological term that describes in patients with uh, liver metastasis, and specifically is not known why, but specifically in patients with breast cancer. Almost all reported cases had been in breast cancer, and specifically with receptors of estrogens or progesterone positive. After receiving chemotherapy, they develop like a retraction of the liver parenchyma around the metastasis, and and behave like a theoretic patient, developing portal hypertension and also ascites and varices, but hepatic encephalopathy is not common in these patients. So this is not compatible neither with pseudocirrhosis, and there's a bit of disconnection between the radiological description and the presentation. So I thought that she must develop a shunt. Yeah, that's this more likely explanation, I think.
Wow. What a case. What a case you brought it today, Debbie. Thank you for sharing this with us. And kudos to you for being so dogged about trying to pursue the final diagnosis of the shunts. I will say I brought it up earlier. My colleague went through the same exact thought train in terms of redoing a CAT scan of the abdomen with IV to specifically look for that shunt. So I think that's a really important teaching point. If you really want to rule it out, make sure that your scan is being protocoled and the contrast shot appropriately to like really look for it. But thanks again, Debbie. It's so good to see you.
This is
You
such a
were all
great.
right since the beginning. So in the first aliquot, Andrew mentioned hyperammonemia, and I was okay. She already knows.
Yeah, it's just so cool to be part of this and to share um, the nuances of not just how to even label hyperammonemia, but the nuances about how that is just the beginning of a journey on what kind of hepatic encephalopathy. And even when you name the kind of hepatic encephalopathy type B, it can be very tricky. Is it the medication? Is it nutritional? Or is it a systemic shunt? And this patient probably was at risk for all three of them. Um, Really, really educational case. I'm really grateful for you sharing it, David. And Andrew, I couldn't agree more with David. I think you were ammonia was on your conscious and subconscious mind, and I'm glad it bore fruit, and I'm glad this person got an answer for what's going on with them. All right, Anmol, last but not least, we'll hand the mic to you for the teaching points.
Thank you for such an amazing case, and I'll try to rush through the teaching points. So first, we thought that the patient had altered mental status, and we think about the emergent causes which we need to rule out first. First, we can go for the fingerstick blood glucose to rule out hypoglycemia. This we are revising the scan mnemonic, and then CT head to rule out any acute intracranial pathology, and then ABG or VBG to rule out acidosis or alkalosis, and then to check if the patient is having Narcan overdose. Then we shift over to the main causes which we know for the altered mental status, that is metabolic, infectious, neurologic, and toxic, that is the MINT mnemonic. Metabolic, for that, we think of having a basic metabolic profile to check for any electrolyte abnormalities, uremia or hyperammonemia. And then infection, we can think of either inside the CNS or outside the CNS. It could be inside the CNS, meningitis, encephalitis, or brain abscess. And then neurologic, we can think of just like AKI, pre-brain, intra-brain, and post-brain causes. Pre-brain means either decrease in blood flow or increase in blood flow. With all the examples as Dr. Andrew mentioned. Then intra-brain, that is a lot of fluid around brain, which can be in edema or CNS vasculitis. And then post-brain, it could be cerebral venous sinus thrombosis. And then it is very important to know if the patient, the problem is restricted to brain or it is systemic, like a cancerous metastasizing towards the brain, which is causing the altered mental status. And it is important to know if the problem is focal or it is diffuse problem, because if it's a focal problem, we'll have some other associated symptoms as well. Like if it's specifically affecting the frontal lobe or temporal lobe. And then this patient had a history of cytotoxic chemotherapy, which makes us think that the patient could have thrombocytopenia, which could lead to brain hemorrhage, and that's why CT head is important. And then another thing, we saw that the patient was on lorazepam. So overdose of lorazepam, especially in the setting of COPD, can lead to hypercapnia. And therefore, we need to evaluate that too. So important investigations, BMP and VBG. Another thing, we understood that BUN and creatinine, we cannot for sure say that uremic encephalopathy can be present. It can be present with even if BU and creatinine are normal, and even if BU and creatinine are high, then also uremic encephalopathy might not present. So it's a not reliable investigation. Then we thought about the hepatic encephalopathy. So we got to learn there are three types of hepatic encephalopathy: type A, type B, and type C. And ammonia levels can be diagnostic for type A and type B, and not much for type C. Type A is present in acute liver injury. Type C is present in cases of cirrhosis. And type B is an interesting type, which is actually high ammonia with normal liver enzymes. And it is because it bypasses the urea cycle with no existing liver disease present. And drugs like 5-FU and valproate, they inhibit urea cycle and can cause type B hepatic encephalopathy. Then we saw that this patient had missed negatives. So we thought about some causes which can cause sudden extrinsic AMS, like urinary retention and constipation being the benign causes. And then we had the mild respiratory alkalosis, which everyone thought could possibly indicate hepatic dysfunction. And we had radiographic evidence of liver dysfunction with underwhelming labs. Therefore, important to have ammonia levels checked. And there we had hyperammonemia. And the pseudocirrhotic changes are basically the imaging findings of cirrhosis that occurs with hepatic metastasis and is most common following chemotherapeutic treatment of certain cancers. So the treatment of this patient would be to address the nutritional deficiency with zinc and replace 5-FU with some other hepatoprotective drugs and introduce ammonia scavenging drugs to treat that hyperammonemia and look for any portal venous thrombus. And it's very important to check ammonia levels since this patient had two admissions just for that case. So that is pretty much it from my side. And the patient was diagnosed with type B hepatic encephalopathy. Thank you so much.
Amazing. That was such a great recap. How are you tired after that 3-minute monologue? Good. Oh, that was wonderful. Really, really nice job on Well, you should take a look at the chat before you go. It's full of praise for your outstanding teaching points. Alrighty, thank you, David. Thank you, Andrew. Thanks, Reyes, for the scribing and more for the teaching points, and I hope to see you guys tomorrow. Sammy is back, who presented a really cool case yesterday for RLR VMR, so I think it'll be a really good one. Bye.
Thank you
Hi,
for the
everybody.
opportunity.